first. So we're now going to move on to our second and solo presentation from Professor J.P. Brito, who's the Medical Director of the Mayo Clinic Shared Decision-Making National Resource Centre, very title, and Principal Investigator in the Knowledge and Evaluation Research Unit there, the co-unit. And J.P. is going to talk to us about
patient-centered diagnosis.
Patient-centered diagnosis. But you need to practice the
Yes, I got it. Yes. So thank you, Ayana, for the presentation. I'm a healthcare delivery researcher, also an endocrinologist. I do decision-making research as well. And I'm actually going to include that kind of research in one presentation. So it's going to be a little bit challenging, but I'm going to try to do that. I have no disclosures. Over the last decade, we have done a lot of research in overdiagnosis. We have done research to understand the extent of the overdiagnosis, to understand the magnitude at which conditions are overdiagnosed. And we have portrayed overdiagnosis in something like that. A figure that shows the incidence of thyroid cancer in the United States over the last 3 decades, showing the line going up with the incidence and mortality being flat, that strongly suggests that we are overdiagnosing small cancers that have indolent course. We have also portrayed the issue of diagnosis with maps, practice variation. This is a study that we did in South Korea. By doing this, we understood that in the South in 2002, we started seeing the signal that overdiagnosis was happening, and that is spread like a virus to the whole country. We have also portrayed the issue of overdiagnosis as a consequence of overdiagnosis, which is overtreatment. This is a recent paper from Welch that actually shows that the frequency of thyroid surgery has increased in parallel to the increased frequency of thyroid cancer. And it's not the more conservative surgery that we're doing more often, actually it's the more aggressive surgery that we're doing more often, which is when we remove the whole thyroid as opposed to remove part of the thyroid. And finally, we have also portrayed the issue of diagnosis with overtreatment with something like that. Patient came for neck pain, had an MRI, had a nodule. When she left the clinic, she had no thyroid, and she had a scar. But overall, what we have said and we have portrayed the issue of overdiagnosis is an issue of the evidence, a gap in the evidence. When doctors and patients or doctors are doing something that is not evidence-based, they're requiring tests, they're going patients for treatment that they might not need, but clearly things that they are not evidence-based. And the response to that has been a response based on evidence. Campaigns like the Choosing Wisely campaign that said, put experts together and said, if the problem is that, don't do it. Don't do ultrasounds in patients that have no symptoms. And that's the case of the recommendation for thyroid cancer. But these trends, the ones that we use to portray overdiagnosis, they only tell half of the story. They only tell half of the story as if we were watching far from the moon. So I say, in the Earth, I can see that in the last 30 years, that number of people were overdiagnosed with thyroid cancer. But they can only tell half of the story, and they should not tell the whole story. As we start zooming in, we start seeing faces. We start seeing people behind these trends. And then we start seeing people of these forming the trends that we see them in the encounter. Actually, we cannot see the background anymore. We cannot see the trends. Actually, we cannot see the overdiagnosis happening. We only see people coming to us for a difficult situation when different in biology and different context, values, and preferences. So what I'm going to propose today here is that population level overdiagnosis is not the same as patient level overdiagnosis. These are the more common definitions of overdiagnosis at population level, which means that we diagnose someone with a condition or a new condition that has no real benefits, but most likely has harms. In other words, we bypass the evidence from the biology of that patient and we create plans of care. So we are overdiagnosing that patient. But usually patients are not only things about biology, they have a specific context, different values and preferences. So what I'm proposing here is that when you bypass that, you're also overdiagnosing somebody. And in fact, the issue of overdiagnosis doesn't really apply, the nomenclature doesn't really apply anymore. And I want to call that extra diagnosis. Extra diagnosis as the process by which a person's problem is investigated in such a way that exceeds what should have been appropriate given the person's biology, this person's biology, context, and values. So in other words, extra diagnosis is a diagnosis that doesn't fit. So let me give an example when diagnosis does not fit. Mrs. Smith is a 72-year-old woman, and she's going to the doctor because she's feeling tired or fatigue. And the doctor runs a series of tests and finds out that actually she might be depressed. She might have some depression, and prescribes antidepressants. Mrs. Smith goes to home. She does not actually fill the prescription. She doesn't have money to pay for a pharmacy. She lost her husband a few years ago. She was doing well financially. She actually was relatively well. But her daughter recently got sick and had to go to the hospital and was discharged. And the medical bills were so huge, she actually had to help her daughter to pay the bills. And now she's struggling financially to pay the daughter's bills. And now she's struggling financially. So she keeps thinking about it. She cannot sleep. She gets tired. So yes, she might have been a little bit depressed, but the main problem was a different problem. So the diagnosis did not fit. Sometimes it's not the diagnosis that does not fit, it's the process that doesn't fit. Mrs. Casey is a 40-year-old mom of two. She's a little bit worried now because she has been losing weight for the last 3 months. And over the last few weeks, she actually had fevers. She goes to the doctor, and the doctor says, one of the things that we need to think about is cancer. And it makes sense. Weight loss with fever, you have to think about cancer. And she gets worried, the doctor gets worried as well, and say, okay, I understand we have to do something about it. And say, yes, let me do some testing and we will see you again. She goes to the front desk when usually people set you up for the next appointment. And the people in the front desk tells her that the PET scan that was ordered cannot be done in the hospital. Actually, they don't have a machine. They need to go 3 hours away to have it done. And the next appointment is in 10 weeks. She's a mom of two. She's concerned that she's going to die. She's concerned that she might have cancer. Yet, they need to wait 10 weeks to do the PET scan. She needs to take a whole day away from the kids to have the PET scan done in 10 weeks. The process does not fit. So ideally, we should pay attention not only to the biology of the patient, but to the biography, as Iona has said many times, of the patient, meaning the context, values, and preferences of the patient. But we are very good at one thing, the biology. And it makes sense. 7 plus 3 plus 5, 15 years of training to respond to the biology. Medical school, residency, fellowship, we are getting good at the biology. In fact, we keep doing research about the biology. This in 2009, the government in the United States launched the precision medicine campaign. That was pretty much a campaign to understand your biology from the genes perspective. We are using artificial intelligence now. Actually, a new software just is going to come available to investigate thyroid ultrasounds to find cancer, and it's becoming really accurate. When we develop decision support systems, when someone comes with a symptom, they're going to give us differential diagnosis so we don't miss anything. And that's good. That is actually good if we use them in the right way. But we still do not respond to the context values of the patient we make in the diagnosis. So here I'm going to propose a small framework of 3 steps that people can do it in the clinics. Those 3 steps are, number 1, trying to identify correctly the problem that needs clarification. 2, what are the actions that problem demands? And 3, making sure that that process fits. So let me tell you, number 1 is trying to understand the problem. And the problem could be 1, biological or biographical or both. And of course, again, we are good at the biology to some extent, but we are not good at the biographical issues. Issues about finances, issues about your environment, access to care, your support. We're not good at it. But some of the problems are really more in the biology, and they require a biological response. Imagine a young patient that goes to the ER because of a right lower quadrant pain for the last 24 hours with fevers, usually appendicitis. Clean answer, clean surgery, patient is discharged. Not a good thing to think about the context and values and preferences. Patient will die if we don't do surgery. So that's one of the extreme of the other things. But what about another young male that goes to the ER, frequent admissions to the ER because of shortness of breath? Every time that he goes to the ER, he gets prescribed an inhaler. But the problem is not the shortness of breath, not that he might have asthma, it's that he cannot afford the medicine and he cannot go to see the primary doctor. So then we start thinking about the biography. Schwartz and colleagues actually shown that 1 out of 2 contextual problems are missed or overlooked during the development of plans of care. So there are many, and we miss the context. We medicalize, we label, and we do unnecessary testing. So how can we do better? This is an example of tools that can support contextualizing. We can contextualize care. This is called ICANN. This is a tool that was developed by researchers in my research group, in which patients fill this before the encounter. So you have here aspects of your life, and you also have questions about whether or not that aspect of your life brings satisfaction or burden. And you can actually check both. So you can say, for instance, my work is burden, my family is satisfaction, and things like that. So you bring this to the encounter, and the doctor says, why is this a burden? Tell me more about it. It sparks conversation, making sure that the plan of care or plan of testing is contextualized. Let me give you an example how that might work for Mr. John. Mr. John is a 40-year-old. He's going to the doctor for checkup. Actually, his wife asked him to go to the doctor and said, make sure everything is fine. Goes to the doctor, and the doctor runs the questions, physical exam, and everything. And when he gets to the social part of the story, he says, do you drink alcohol? And John said, yes. It's okay, let me ask you 2 questions. And he runs a series of questions that are called CAGE questionnaire to identify patients with alcoholism. And he actually responds yes to the need to cut down, and also yes to the feeling of guilty when he drinks. So that raises a red flag. And maybe John is an alcoholic. But let's use a different approach to understand that from Mr. John. Let's use a similar tool, the one that I showed you before, but this one is for alcohol. What it does is presents a tool like that and tells the patient, tell me, of those aspects in your life, alcohol makes those aspects worse or better. So Mr. John said, alcohol makes, I'm concerned about my body, I think it makes it worse. It might make it, in the future I can get sick if I keep drinking alcohol. Actually, it's good for my work. And the second part of the tool, it says drinking helps me with, actually feel relaxed when I drink. I can be more social when I drink. It happens that he's actually works in advertising, and he needs to travel all over the country, give the speeches to people in front of conferences like this, and he hates the fact to talk about in front of people. He gets very anxious about talking to people. He drinks wine a little bit to relax himself. And later on, to those networking events, he actually needs to drink more wine to be able to network with people. It's part of his job. So alcoholism is not a diagnosis. He has social phobia. And he might need a different treatment, or he might not need treatment at all. The alcohol is a way that he found to support himself. So he's not an alcoholic. So the second component of patient-centered diagnosis is trying to identify the actions that the problem demands. And this is where the research on choice decision-making might be important. So I'm going to present an example of a tool, how to present options to patients when they are making decisions about diagnosis. A tool that was developed by Eric Heswitz. He's an ER doctor that works for a research group. This is the case. Imagine that you have a 5-year-old kid that actually just fell down and hit his head, has a head trauma. And you get concerned, you take your kid to the hospital, and there are 2 possible diagnoses. One is just a concussion, meaning the brain of the kid just moved inside the skull and nothing will happen. Or he might actually have brain injury. What are the risks of brain injury? 1 in 100. But having brain injury is not a good thing. So, 2 possible options. You can have a CT scan of the head to find out what's the problem right now, or you can go home and you can follow the symptoms. So this tool helps parents to present both options. And says, for instance, if you choose or we think about head CT as the best option, we can actually know that now. It's rapid diagnosis, but we might need to sedate your kid. We have to put medicines to the vein because we have to put your baby or your kid, in a relaxed way, so we need to use sedation. And it might be expensive because the CT scan, I'm not sure about your insurance, but it might be expensive. And we might find irrelevant findings, meaning we can have overdiagnosis of incidental illness, things like that. And you might need to wait in the ER another 3 or 4 hours to have a CAT scan. That's one possible option. The second possible option is actually go home. You don't get to know the diagnosis right now, but you can monitor symptoms at home. It will not be radiation, it will not be anything about sedation, it will be no cost. And you will probably need to go to the ER, leave the ER right now, so you don't have to wait. So you have those 2 options. And the idea is that parents can try on those options in their heads with the kid. Some parents will feel comfortable watching the symptoms and signs at home and say, I can do it. I can certainly, if he gets sick, I can bring him back. And some parents will not. Some parents can wait in the ER for many hours, some parents cannot. So as they navigate the option, they can make a decision which option is best for them. As this is a way to support decision-making for the diagnostic test. But the last thing is about fitting. It's about how to make sure that the diagnostic plan fits the patient. And this has 3 components. Making sure that it fits intellectually, the patient understands and knows why he's doing the test, feels right. Actually, and I feel why I'm doing it. I feel right. It feels right for me. And patients know how and when to implement this plan. So remember this patient. She actually understood why the test was done. She understood that actually emotionally feels correct. It feels right. But practically, it didn't make sense to wait 10 weeks to do the PET scan. It didn't fit very well. So why we actually also, we need to think about fit when we're doing this. And that is the field of diagnostic errors. It's when we order tests and nobody follows the test. We order tests that patients have no idea that we are ordering the test. We order tests that are too expensive for patients. Or we order tests patients do not understand why. And this is the whole reason why nobody follows the test, and maybe there are 30% or 20% of diagnostic errors. And we are developing a new technique based on reconciliation. We're already doing reconciliation with patients, but for medicines. We sit down with patients and say, okay, you are taking 20 medicines. You are taking medicine A. Why you're taking medicine A? What is the dose that you should be taking? What is the benefit of that? So the idea is to try to compare, discuss, and agree on the best medicines for you. The same thing we are developing in a prototype for clinicians to teach them at the end of encounter, to make sure that they understand why they are doing the test, the purpose of the test, they understand the why, and they understand the how. And we are calling it the diagnostic reconciliation, which is the third component of the patient-centered diagnostic plan. As everything in medicine, this is just a tool. It only can help you in different circumstances. And this is a figure that shows in which circumstances this might be helpful. Think about the vertical line at the value of this approach, and the horizontal line, the area of uncertainty. In the extremes, this should not be useful. When you are thinking about someone who has hypertension and has low sodium and feels a little bit dizzy, you just run electrolytes in the blood. There is no need to engage the patients to the end. So, just in the middle, when there is a lot of uncertainty, we don't know how to proceed, I think this approach like this might be helpful. And with that, my take-home points is that I believe strongly that patient-level diagnosis is different. I think it's a possible way to call it with the extra diagnosis, which is pretty much diagnosis that doesn't fit. And a possible solution to that is an approach that I'm calling patient-centered diagnosis with 3 components. Thank you very much. That's my research unit. That's my second family. And if you have questions, please, it's my Twitter handle. Thank you.